Cardiology fellows and a lot of cardiologists confuse the issue of LVEDP and pulmonary capillary wedge pressure. They commonly believe that those two values are equal, except in mitral valve disease. That is not perfectly true. There are many more case scenarios of discrepancy between LVEDP and mean wedge pressure, and those cases are clinically very relevant, in my opinion. So it is important to understand the difference between the two, particularly that we measure LVEDP in the cath lab every day, many times a day. I will start with this case. This is a patient with systolic heart failure and an ejection fraction of 30%. This is an LV recording, and this is the scale. And I have two questions here. What is the LVEDP of this patient? And should this patient receive extra doses of diuretics? So first answer, the LVEDP is the LV diastolic pressure after A wave. This is the LVEDP. This is P wave here. This is a big A wave, LV A wave, like you get LA A wave, you get LV A wave as well. And this is the LV end diastolic pressure, the point after it. This is the LV end diastolic pressure. And we take it in end expiration. You see the point here as well as here. But we take the highest point, which is end expiration, where the respiratory pressure is 0. We try to avoid the effect of the negative inspiratory pressure. In patient actively exhaling, the end expiration may be a positive pressure, so we may not take end expiration. We may take a point somewhere in between, 2/3 up from inspiration and 1/3 down from expiration. But anyway, in this particular patient, it's end expiration and it's about 30, 31 millimeter of mercury. So it's quite high. So the second question, this patient should receive diuretics? I think many doctors will answer, yes, he should receive extra diuretics. I would argue no. This patient's LVEDP is high, but his mean wedge pressure is very likely normal. I think his mean wedge pressure is equal to that point here before A wave, what we call pre-A LV, and it is equal to about 13, 14 millimeter of mercury. Therefore, he should not receive extra diuretics. Rather, this patient has significant myocardial disease causing this massive rise in pressure during atrial contraction. It's a sign of an ill myocardium in this patient, not a sign of volume overload. I don't think he's volume overloaded. He just has a very ill non-compliant myocardium. And what he needs myocardial therapy, disease-modifying therapy, Entresto, spironolactone, beta blocker, SGLT2 inhibitors. I think actually, if this patient, if you give him diuretics, you'll cause him to have a kidney injury. Based on this tracing, he doesn't seem to be overloaded. This is another recording of this patient. Again, you see that a huge A wave, high LVEDP, but normal pre-A LV diastolic pressure. So here is the explanation. What's the difference between LVEDP and mean wedge pressure or mean LA pressure? I will lump together wedge pressure and LA pressure. I will consider them equal, certainly equal when we talk about mean LA pressure and mean wedge pressure. So LVEDP is assessing the LV diastolic pressure at one point only. After A wave here, the black tracing is the LV, the blue tracing is the wedge pressure. So LVEDP is assessing the LV pressure after A wave and is a good measure of LV compliance. Conversely, mean wedge pressure is assessing LA pressure throughout systole and diastole, not just at that one narrow point in time. So if you have someone with impaired LV compliance, but no significant impairment of LA compliance and no significant volume overload, his A wave will be abnormal. He will have an overshoot of pressure. Both LA wedge pressure and LV pressure will shoot after A wave. However, if he's not severely volume overloaded and if his left atrial compliance is not overwhelmed, that left atrium will absorb the impact of the impaired LV and will prevent a rise in the pressure outside that A wave. So this patient would not have a high V wave, and the mean wedge pressure will be normal. V wave is really the best representation of overwhelmed left atrial compliance. V wave is atrial compliance. A wave and LVEDP are ventricular compliance, okay? So in a patient with compensated LV dysfunction in whom the left atrial compliance is not overwhelmed, the A wave will be high, but the mean wedge will not be high. And in this patient, the LV-EDP will be significantly higher than the mean wedge pressure or the mean LA pressure. So here is what we find in compensated LV dysfunction. LVEDP is higher than mean wedge pressure. In general, LVEDP is almost always equal to end diastolic wedge pressure and is usually equal to mean wedge pressure, but not always. So LVEDP almost always equal to end diastolic wedge pressure. Only in cases of mitral stenosis, the end diastolic atrial pressure will be higher than LVEDP. But the main discrepancy is not between end diastolic wedge and end diastolic LV. It's between mean wedge, which is what we use to assess for pulmonary edema and to assess the volume status of the patient. And there's a discrepancy between that mean wedge and LVEDP. And this slide summarizes what I just described. LVEDP is assessing LV pressure at one point only after A wave and is a good measure of LV compliance. Conversely, mean wedge pressure assesses LA pressure throughout systole and diastole and reflects LA compliance, particularly when we have large V wave. So LA compliance may still be absorbing the impact of the impaired LV and preventing a rise in the mean wedge pressure and preventing pulmonary edema. So those are more illustrations of those concepts. This is compensated left ventricular dysfunction. This is another case of compensated left ventricular dysfunction where the left ventricular dysfunction is more pronounced, kind of similar to this patient. With A wave, with atrial contraction, you get massive rise in A pressure and a significant rise in LVEDP, yet the pre-A LV is normal and the mean wedge is normal. Again, you get a rise in post-A or A wedge pressure, but not outside that A. Conversely, this is the decompensated left ventricular dysfunction. In this case, compared to those, the atrial compliance is overwhelmed, and now the wedge pressure and the left atrial pressure will dramatically rise, and you'll get a big V wave. And in this case, the mean wedge pressure will be equal to LV end diastolic pressure and LA end diastolic pressure. Actually, it may exceed them. Depending on the side of the V wave, the more you are decompensated, the more that left atrial compliance is overwhelmed, the bigger the V wave, and the more wedge pressure is higher than LVEDP. Therefore, in compensated left ventricular dysfunction, LVEDP is frequently bigger than mean wedge pressure. In decompensated left ventricular dysfunction, LVEDP is equal to wedge pressure or is inferior to that mean wedge pressure, depending on how big that V wave becomes and how decompensated you are. So if you're looking at an LV pressure and you don't have a wedge pressure recording, you're just doing your routine left heart catheterization, you can indirectly imply what's the mean wedge pressure is just by the shape of that LV diastolic pressure. And that's what I want you to understand from this talk. Understand the shape of that LV diastolic pressure. In this patient, I was able to tell that this patient has a normal mean wedge pressure despite that very high LVEDP. And this is how I can tell. In compensated LV dysfunction, the LV diastolic pressure is fairly normal, as it is here, throughout most diastole, and you get that massive overshoot during A wave, during a very narrow period in time. Those are the patients I know have significant myocardial disease, but they are not in pulmonary edema right now. They are prone to having it, but they are not in pulmonary edema right now, and they don't need extra diuretics at the moment. Conversely, when you're in decompensated left ventricular dysfunction, your LV pressure will be high throughout diastole. It may be high in this way, where it's high throughout, with further rise with LVEDP, but you're high all the way. Or it could be a steep, gradual increase in diastolic pressure. But regardless, it's not normal followed by an overshoot. It's overshooting throughout, or it's very high and plateaued throughout. So you see those two, you know this is decompensated left ventricular dysfunction, and the mean wedge pressure in this patient is either equal to that LVEDP or even higher depending on the V wave. Whereas this one, the mean wedge is probably lower than the LVEDP. This is an actual case scenario of a patient. Look at that LVEDP. See, the LVEDP is high at about 30 millimeter of mercury, but there's a progressive rise in LV diastolic pressure. The pre-A LV diastolic pressure is high as well. So this patient would benefit from extra diuresis. Okay, his LV diastolic is high throughout. His pre-A LV pressure is probably around 25 millimeter of mercury. This is another case. Again, similarly, this patient is like that one, is like this one. He's high throughout diastole, and he never even dips. He's having that high plateau diastolic pressure that's high all throughout from the onset, with an extra high during A wave. So this patient also likely has a very high wedge pressure that is equal or exceeding LVEDP. That's another case scenario of, again, a very high LV diastolic pressure throughout, not just during LVEDP. In this case, again, LVEDP does represent the mean wedge pressure, and maybe the mean wedge pressure is higher. Another important idea, I want to mention, that big V wave, I kind of alluded to it when in the wedge pressure, is very much due to impaired left atrial compliance. Most big V waves are not mitral regurgitation. They are just impaired left atrial compliance and decompensated, severely decompensated left heart failure. It could be mitral regurgitation, but most often is not, okay? So there is another explanation for a big V wave, a common explanation nowadays, which is atrial fibrillation. Atrial fibrillation will inherently exaggerate your V wave. Even if you take a normal individual, you make him go from sinus rhythm to AFib, inherently his V wave will rise in height. For a couple of reasons. For one, your atrial compliance becomes impaired in atrial fibrillation, and that can raise your V wave. And two, when you lose atrial contraction and you lose atrial emptying of that atrial reservoir, this will cause the atrial volume to increase in systole and therefore overwhelm the already reduced atrial compliance from AFib, leading to V wave augmentation. Therefore, when you're in atrial fibrillation, inherently you exaggerate V wave, and wedge pressure is far more readily to exceed LVEDP in this case than if you don't have AFib. So if you take somebody with decompensated heart failure and AFib, you will easily have a large LA V wave or wedge pressure V wave that could easily make the wedge pressure exceed the LVEDP. Okay. So I described cases where LVEDP is higher than mean wedge pressure, mainly compensated LV dysfunction, and cases where wedge pressure is higher than LVEDP, mainly decompensated LV failure with overwhelmed atrial compliance, including an exaggeration by added atrial fibrillation. So this is kind of a summary idea. LVEDP is better diagnostically for left heart disease than wedge pressure, as it rises earlier than wedge pressure. Conversely, wedge pressure is better prognostically than LVEDP. It implies that not only the LV compliance is impaired, but the LA compliance is overwhelmed as well. So when you start by having LV disease, left ventricular disease, your LVEDP rises, the wedge pressure is still normal because the left atrium is absorbing this impairment of left ventricular compliance and is preventing the rise in wedge pressure. Eventually, with further impairment of LA compliance and further volume overload, the wedge pressure will rise and the V wave will rise progressively more and more. So therefore, wedge pressure rise is more delayed and implies more advanced disease. And that's why it has a stronger prognostic connotation. However, LVEDP is better diagnostically for left heart disease. Okay. And this is a paper in JACC Heart Failure highlighting this idea that wedge pressure is more predictive of adverse outcomes in heart failure with preserved ejection fraction than LVEDP. Again, because it's a more advanced stage. It's a stage where not just the LV, but the LA compliance is overwhelmed, beside the fact that you may also have atrial fibrillation at this point, further exaggerating your V wave and your wedge pressure and affecting your prognosis. The relevance of LVEDP versus wedge pressure also depends on what you are trying to address. If you are addressing whether the patient has pulmonary edema or having dyspnea at rest or minimal activity, then wedge pressure is the better evaluator of the status of the lungs and how overwhelmed the lungs are. Conversely, if you are assessing if his LV is causing exertional dyspnea, then exertional wedge pressure or LVEDP, including resting LVEDP, are more sensitive than resting wedge pressure to detect an abnormality. Also, if you are assessing if the patient has heart disease that is well diuresed and well compensated now, but is at risk of decompensation, or if you are assessing if he has pulmonary hypertension that is a precapillary versus postcapillary, then again, LVEDP or exertional wedge pressure is the better evaluator. This is a summary slide of all I've described regarding the relationship between LVEDP and wedge pressure. Normally, LVEDP is equal to end diastolic wedge pressure in almost all cases except mitral stenosis, and is often equal to mean wedge pressure. So the old dictum that LVEDP equals mean wedge pressure is often true, but there are way too many exceptions, as I described. LVEDP is higher than mean wedge pressure in compensated LV dysfunction and in AI. LVEDP is equal to mean wedge pressure in decompensated LV failure and may be lower than mean wedge pressure in decompensated LV failure, depending on how overwhelmed the left atrial compliance is and how large the V wave becomes. So mean wedge is higher than LVEDP in more advanced decompensated LV failure with large V wave, especially decompensated LV failure with AFib. And in this entity called the stiff LA syndrome, which is a subset of heart failure with preserved EF. So this is a subset of heart failure with preserved EF that may have higher LA pressure and wedge pressure compared to LVEDP. And many of those have AFib. Other causes of mean wedge higher than LVEDP are MR with large V wave and MS. But those top one are more common actually than mitral valve disease. Now, in all those cases, mean wedge is higher than LVEDP, but end diastolic wedge tends to be equal to LVEDP, except in mitral stenosis. So here to show you. So in those cases of decompensated LV failure or MR, the mean wedge is higher than LVEDP, driven by that large V wave. but the end diastolic wedge is equal to LVEDP. The only case where end diastolic wedge exceeds LVEDP is mitral stenosis, where by definition, a hemodynamically significant mitral stenosis is characterized by a lack of diastasis in end diastole between the wedge pressure and the LV pressure. I want to highlight something related to my prior talk on pulmonary hypertension. Still, in pulmonary hypertension, wedge pressure is a very good diagnostic marker of precapillary versus postcapillary pulmonary hypertension. You don't often need to obtain LVEDP. I do want to highlight again those caveats. One, in pulmonary hypertension, the most common caveat of wedge pressure is getting a falsely high wedge pressure. That is in reality a damped PA pressure, causing you to falsely call the patient as postcapillary PH. Okay? So now, once you've obtained a true wedge pressure, there are still some caveats related to this current talk. Even when you do get a true wedge pressure, LVEDP has more diagnostic value than true wedge pressure, as it is more likely to be elevated in compensated LV dysfunction with normal wedge pressure. So if you have a high wedge pressure, you have to make sure it's not a fake damped PA pressure causing the wedge pressure to be falsely high. That's the biggest caveat in pulmonary hypertension assessment. Now, once you've ensured that your wedge pressure is a true wedge pressure, you still have some caveats. The caveat being that you can have compensated LV dysfunction with a wedge pressure that is normal at the time of your study, but that rises at times and causes that pulmonary hypertension, or that was high at other times and caused that pulmonary hypertension that is still now lagging behind the normalization of wedge pressure. In those patients, frequently they would have normal wedge pressure, but high LVEDP. So LVEDP is more frequently diagnostic than wedge pressure in those patients. And one could argue about doing LVEDP in all pulmonary hypertension assessment. However, this is not necessary. I think if your wedge pressure is normal, but you have concerns, the patient has a clinical and echo features of diastolic heart failure, then in those cases, just perform stress wedge pressure. Instead of measuring LVEDP, which is actually not as reliable as stress wedge pressure, just do stress wedge pressure. In terms of reliability to diagnose left heart disease, you go in this order from wedge pressure to LVEDP to stress wedge pressure. The highest yield is with a stress wedge pressure. The lowest yield is with a wedge pressure. Then you have LVEDP, then you have a stress wedge pressure. So the best is to just do in those patients that where you are suspicious of left heart disease is to do stress wedge pressure using exercise testing or fluid challenge or vasodilator challenge. Those are just a couple of studies that showed that in patients with pulmonary hypertension, LVEDP is much more sensitive to detect left heart disease than wedge pressure. But again, I think wedge pressure is quite good as long as you put it in context and do stress testing or stress wedge pressure to unveil left heart failure as needed, depending on the context. I want to show another case here that further illustrates those discrepancies. This is a patient in whom we were trying to access the left ventricle, and we access the left ventricle using a Tiger catheter from a radial axis, but somehow the tracing we obtained from this picture, we seem to be in the left ventricle, but this is the tracing we obtained. So the fellow didn't know what that is. He thought that we were against the wall and we are obtaining a damped left ventricular pressure against the wall. But this is not the case. And I want you to be able to guess what is this. This is the catheter and this is the tracing we obtained. Look at it. This is a real waveform that has two waves during each cardiac cycle. You have a V wave after T and an A wave, V wave and an A wave. This is actually left atrial pressure. So this has been well described. Using a Tiger catheter or a Judkins left from a right radial axis, radial axis tends to elongate those catheter. And when you go in the ventricle and flip the catheter, instead of to the apex, flip it backward, your catheter may cross the mitral valve retrogradely and give you left atrial pressure. And that's what happened. And you need to recognize this phenomena. You can do it on purpose, doesn't always work, but at least if it happens accidentally, you need to know it. So this is left atrial pressure in this patient. It is a high left atrial pressure with a mean close to 25 millimeter of mercury. Of note, this is the wedge pressure in that same patient. We had done right heart cath in this patient. You can still see the right heart catheter. This is the wedge pressure in this patient. And this is the wedge and LA head to head. So mean wedge and mean LA pressure are equal as long as you're obtaining a true wedge as confirmed by wedge O2 saturation. So mean wedge is equal to mean LA pressure. That's why throughout that talk, I lumped both of them together. However, wedge pressure, as I've explained in other talks, is significantly more damped than LA pressure. So the V wave and A wave of the wedge pressure are not the same as the V wave and A wave of the LA pressure. They are more damped. It's kind of that you take the tracing and elongate it. This is LA pressure. This is wedge pressure. This is an extra damped wedge pressure. You're taking that LA and you're pulling it apart and damping the V and the A and especially you're damping the dips and the hills. Okay. That's okay. The mean still remains the same. That's why mean wedge pressure is a great surrogate of mean LA pressure. The only caveat of using wedge as a surrogate of LA is when you're trying to assess for mitral stenosis. Because when you're damping that LA, this is LA, this is wedge. When you're damping that LA and elongating those hills and waves, you create a fake gradient between wedge and LV, or you exaggerate the gradient between wedge and LV. So it's definitely not good to assess for mitral stenosis. So wedge pressure and LA pressure are interchangeable in most case scenarios, except mitral stenosis. So I'll go back to this patient. Here we flipped the LV catheter back into the LV instead of the LA, and we obtained this pressure recording. So you can see the LVEDP in this patient. LVEDP is actually lower than the wedge pressure. And this patient has a pronounced V wave. Look at that V wave. The mean wedge is in the 20s, maybe again 23, 24, whereas that V wave is almost reaching and exceeding 35 millimeter of mercury. So he has large V wave, which by definition means V wave higher than 10 millimeter of mercury above the mean wedge pressure. This patient with a large V wave has an LVEDP that is lower than the mean wedge. His LVEDP is here, this patient. His LVEDP is here, is equal to LA and diastolic pressure, which is lower than the mean wedge pressure in this patient. So again, this patient with a large V wave with a decompensated left heart failure has a LVEDP that is lower than the mean wedge pressure. This is his LVEDP, and this was his LA pressure. Okay, his mean LA pressure was about here, driven by that big V wave and that by overwhelmed LA compliance, whereas the LVEDP is at the end of the A wave here, at the descent of the A wave, and is lower than the mean wedge pressure. So I hope this provides you with illustrations of those discrepancies. You can read this paper, this letter I wrote for Jack heart failure a few years ago that kind of summarizes all those ideas I just described. Thank you.